they couldn't come up with any data. We actually put that in our lawsuit. The university's experts could not come up with a single counterexample. It's a very dangerous thing to say, right? Because almost nothing in medicine and science is 100%. You can always find outliers. But natural immunity, people with natural immunity are the safest people to be around. You're not going to get COVID from somebody who's already had COVID.
Okay. So, I mean, there's so many questions that pop in my head just as people are talking here, and we've already got 4 name tags turned upside down. I got to quick ask this one, though. And again, I'm not a medical researcher, but as I was reading about this, it seems like prior to the coronavirus, there were already about 3 coronaviruses that would infect humans and cause a cold, right? Otherwise, it's rhinoviruses. Is Omicron, is that just like one of those cold viruses now? I mean,
Ryan, go ahead. Cole hit it. Yeah.
you can put it down right away.
I was hoping that someone else would take that hot potato.
Oh, is that a hot?
Robert, I can take that.
Oh,
hot
okay,
potato
Dr. Cole.
if you'd like. Yeah, this is an excellent question. We have a new virus right now, Omicron. It has nothing. If you look at your family tree and you see the funny uncle that really doesn't look like the family, and maybe the milkman came along somewhere, that's what Omicron is. Okay, he's not on the family tree. He probably actually snuck into the family somewhere. So it doesn't branch off of the other variants. Omicron has enough mutations. The backbone of it actually looks more like a pre-Wuhan virus from a genetic point of view. It is behaving like a common cold to the point of what Dr. Urso said earlier. It doesn't bind in the lungs like the previous variants did. It doesn't cause the degree of clotting that the scary earlier variants did. We have been blessed with almost a natural vaccine. It is essentially, now if you had COVID and you're COVID recovered, you tend to get less disease with Omicron symptomologically. However, we are finding that those who have gotten the shots are getting Omicron. The vaccines are negatively effective, meaning you're actually getting Omicron at an enhanced higher rate. Now, there's a reason for this, and this is basic immunology. If you get a shot in your arm, you don't have a tendency to, everybody hears about antibodies, but there's a special kind in your tears, your nose, your mouth, called secretory IgA. It's little mops in your tears. If you've had a natural infection, you have high levels of secretory IgA, these little mops in your mucosal membranes, and that mops up virus quickly. The virus, the response from the vaccine, you don't get this physiologically. So we are seeing actually the vaccinated carry a high volume of virus because they don't have this secretory IgA. So this false construct from our federal agencies that this is a pandemic and the unvaccinated are spreading is a pathophysiologic lie. The vaccinated are carrying high volumes in their nose, their tears, their mouth of virus, because the vaccine does not neutralize in that location of the body where the virus comes in. So this is very important. This is why mandates are absolutely now moot, irrelevant, and out the window, and need to go away worldwide like most of the world has done already. This is the funny uncle. This is not SARS-CoV-2, COVID-19. This is COVID-22 meh. You know?
So it may not even be a variant of the coronavirus. This might be a naturally occurring, may not even be a variant of the coronavirus.
It's a coronavirus, no doubt.
But not of the coronavirus. No.
It's essentially, it's going to be a more of a common cold like the other ones you just correctly mentioned that have circulated for decades and years that we've known in the human body. That's part of the reason why many of us didn't get very sick, because we've had those common colds and that good T-cell innate immunity, the ability to say, yeah, I've had a lot of corona common colds, my body can fight this off. You're likely asymptomatic because as you travel the world, you probably had some of those. So yeah, again, this is that funny uncle that doesn't belong. This is a blessing to humanity. The frail, the fragile, the comorbid die of common colds every year, no matter what common cold it may be. So we still need to be cognizant of those things. Do some of the early treatments still work against this and make your symptoms less? Absolutely. Is your risk of death from this one far less? Absolutely. Is your risk from hospitalization far less? Absolutely. Is South Africa opened back up? I've talked to my colleagues there. They're like, absolutely, it's common cold. What a blessing, we're done. We need to do the same.
Dr. Parks. Oh.
Something on the Omicron. I was going to address the PCR test.
No, I want to talk. That was my first question. Okay.
Yeah, I didn't want to get the way it was worded. Is this a separate beta coronavirus? What I wish to say, I've just come from Europe, from the opportunity to spend time, work with, and learn with Dr. Gert van den Bosche, who has been the leading proponent worldwide of the position which I gently suggest the senator and his colleagues really, it merits paying attention to. One of the things about Omicron that's rather odd is that the data are showing that the vaccinated seem to be more prone to becoming infected by Omicron, and there's some indications in the data. I'm going to voice this as my opinion based on the data that I've looked at, primary data from a number of countries. So it's my opinion. There's evidence that Omicron is associated with a higher risk of infection in the vaccinated population, and that increased risk is a function of the number of vaccine doses that one has received. Omicron, we are truly blessed, as I said back before Christmas, that Omicron has such low risk for severe disease and death. However, it's got a warning sign, and it's what Gert has been warning about and what the FDA has acknowledged in the original documents allowing the emergency use authorization, in which they told the pharmaceutical industry that they desired that the pharmaceutical industry would investigate the risks of antibody-dependent enhancement or vaccine-enhanced disease. What Gert has been warning us about, quite stridently, is if we continue to implement this universal vaccination policy rather than the position of the Great Barrington Declaration, which I've supported in multiple op-eds in the Washington Times, among others, if we continue to pursue this universal vaccination strategy in the face of the pandemic, particularly with Omicron now, a much more highly infectious, highly replication-competent virus, what we risk is driving the virus through basic evolution to a state where it may be more pathogenic and more able to elude the immune response. So in sum, I don't wish to scare, we've had enough fear porn, but if we continue to pursue universal vaccination, the high probability is that what we will continue to see is the evolution of additional escape mutants that are increasingly infectious and may well become more pathogenic. This policy of forced universal vaccination is absolutely contrary to all of our understanding about basic viral evolution. We are clearly seeing the development of escape mutants that are resistant to the vaccine. Omicron is not only resistant to the vaccine, but its infectivity seems to be facilitated by the vaccine. And in my opinion, this must stop for the sake of the world. Over.
Again, Dr. Gert van den Bosche, right? He's South African. He wrote a letter to the World Health Organization well before these vaccines were approved, warning about mass vaccination into the midst of a pandemic. And those warnings went unheeded. I've always said, too, when there's so much we don't know,
minor modification.
It would indicate to you some caution.
He's Belgian, but it's a small nuance. He's actually corresponded also with some of the what I believe to be the world's leading vaccinologist, and he asked me to not disclose the name, but a gentleman who has headed major vaccine companies, highly respected, innovative individual, who completely concurs that this is what we're doing.
Okay, Dr. Parks. And again, we're veering in vaccines, which I know we'll get to. And by the way, we have all kinds of questions online, which shows the interest 5 hours won't be enough time, but let's
I just
try and stick to the, kind of the
Right.
the
I want to go
topic.
back to your original
Thank you.
question. So it's possible that you had a false positive PCR test. And I just want to address the PCR test because many people don't really understand what it is. A PCR test amplifies a signal. And the PCR threshold, the number of cycles, each cycle amplifies the signal once. So we go from 2 to 4 to 8 to 16 to 32. And you get to the point where you have a lot of amplified virus. So you need to have that cycle set low enough that you're only getting virus. Because if you have it set really high, if there's no virus there, it's going to amplify something. And you're just going to amplify garbage. And so your false positive may have just amplified garbage when you have 40 cycles of PCR. And so that's something that is really of concern because we're having our athletes tested, where we have all this high mortality in our young people. And we're kicking them out of sports because of false PCR tests, or possibly they had some fragment of the virus, again, parts of the virus. The virus has been destroyed by their innate strong immunity, right? Our young people have very strong immunity. They blow that virus apart. They still have parts, but they're not infective. They get that positive PCR test. Now they can't play sports. Now everyone has to be quarantined, blah, 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 blah. So this issue of the false PCR test really does need to be addressed.
Okay, thank you. Dr. Wiseman, quick. I mean, again, I want to just try and keep this thing moving. There's so much ground to cover.
Yeah, I just want to briefly pick up natural immunity, and I want to point out two very important studies that show either 88% or 77% protection from natural immunity, and the studies were performed by Pfizer and Merck.
Now, when you say natural immunity after a COVID infection, by the way, I did have antibodies, so I'm...
So in Pfizer, the Pfizer study for the Pfizer study for the vaccine, excuse me, and the Merck study for the molnupiravir, they looked at people who were already seroprevalent at the time of the study. And when you compare those people, the placebo groups that were either yes seropositive or no or seronegative, there was an 88 or 77% protection against COVID from Pfizer's own study and from Merck's own study. So thank you Pfizer and thank you Merck. 77, 88%. That's very important.
And again, Dr. Alexander talked about 140 different studies that showed...
Yeah, well, I think these are very important. I mean, yeah, very 140, but I'd like to quote Pfizer and Merck. Thank you.
Okay. That's what information they do make available. Dr. Merrick?
Yes, so just to carry on your question.
Yeah, Mike.
To follow up on your question and what Dr. Urso and McCulloch have said, the most important factor in determining progression of disease and symptoms is viral load. The viral load in your nasopharynx is really important. So that's where the ACE2 receptors are. That's where the virus replicates. Many factors affect the viral load, as we heard, secretory IgA. But it kind of makes sense if you know where the virus is, kill it where it is. Kill it. And we have oropharyngeal and nasal sprays that will kill the virus within 5 seconds. Why aren't we doing that? I travel with my own little nasal spray because I don't know when I'm going to be infected. I sprish it in my nose. It is a simple, cost-effective way to control the virus. Just squish this in your nose.
You realize I was ridiculed for about 72-hour time period for just mentioning potentially gargling with some, after these studies show this. So you're treading on dangerous ground here, Dr. Merrick.
Yeah, I mean, gargling is good because it's good for your bad breath anyway.
That's why I said, what's the worst outcome? You have fresher breath?
Yeah.
I mean, by the way, that's the truth of all of these things you're talking about. All these cheap, generic, repurposed drugs, we know the safety profile. Why not give them a try? That is what has boggled my mind. Why have doctors been so reluctant to practice medicine? But Dr. Risch.
I just want to respond to something that Dr. Malone said about the...
A little closer.
About the potential occurrence of a new and more pathogenic strain, that Omicron has essentially pushed out all of Delta. According to the CDC surveys, that we're now seeing maybe 1,000 cases of Delta a day compared to the million of Omicron a day, and it's going away threefold per week. Omicron appears to convey immunity to previous strains, and so it's extremely unlikely that a new pathogenic variant would come out of any previous strain of COVID. If one were to come out of Omicron, it's unlikely to be more seriously pathogenic because of the 50 mutations that it already has. It would have to essentially reverse mutate back into a more pathogenic variant, which seems at least relatively unlikely. So I think we're probably in pretty good grounds for expecting not to face a more pathogenic variant, but to face, Omicron's already got dozens and dozens of its own variants now, and we're likely to see those circulating, and maybe more so next fall. But it's still very likely to remain a cold-like virus with all of its mutations.
As I say, from your lips to God's ears, essentially what Harvey is asserting is the thesis that many of us have hoped for, that Omicron would function akin to a live attenuated infectious vaccine. And I share your hope.
And he's right, real quick as a science nerd, because of that furin cleavage site, which we see in the laboratory setting and in creating modifications of viruses for enhancement and function, that furin cleavage site isn't really being split and causing the S2 and the S1 to split off in Omicron. Again, it's more of a common cold, it's a blessing. That's why we're not seeing all the effects. And to Dr. Rish's point, to Dr. Malone's point, absolutely right. We're seeing the behavior giving back immunity. Hallelujah. The mandates are now unnecessary because we have a new virus that really doesn't have the genetic potential to go bad.
So what you've witnessed is at least a slight disagreement between our experts here, and that's, again, I wish we had truth and certainty, but there isn't. And so the only way you're going to find truth, the scientific method, is to be skeptical, question each other, and discuss it, which has not been allowed. Before we move off the trying to stop the spread, and I do not want to spend much time on this. I want one person to take this one up. The efficacy of masks. Somebody want to just? Who's?
Paul Alexander.
Paul, okay.
While he's coming up, I'll just say,
what are you,
if
bunch of
if all those things fail, we have things like ivermectin and hydroxychloroquine that actually prevent the spread, right? So even if we have a more infectious clone, if we start using these medications, then we can stop the spread.
I see Steve Kirsch has stepped up the microphone too. He's got an example, I think, of masks that might work, but again, quickly, because I don't want to spend much time on this. There's more important issues.
Two things quickly. I'll touch on masks, and Steve will help me. To reiterate something that Dr. Malone said about Dr. Gert van den Bosch, I think the key point he was making is, had we been using a vaccine that could sterilize the virus, that could stop transmission, we would not be in this situation, whether or not the vaccine is needed. And the problem here is this vaccine does not stop infection, does not sterilize the virus, so it does not stop the transmission. You can never, ever get to population herd immunity 100% with these vaccines. Impossible. Now, and there's also, Dr. Malone mentioned the data. We have some brand new data from the UK and Scotland this week, the third week of reporting for 2022, which demonstrates conclusively that the vaccine is driving, the second dose and third booster dose is driving massive infections in the vaccinated, and it is a big, big problem. In terms of masks, and I know Steve will speak eloquently too, we pulled together 150 studies published in the Brownstone, and we could say this. When we looked at all of the comparative studies, there are just two RCTs, which is one is a Danish mask study, and that had a problem to be published. That shows basically that the masks are ineffective in terms of curbing infection. There was one RCT, cluster randomized, out of Bangladesh. It went from zero effect to about a 13%, very modest reduction in risk. The body of evidence, and I speak as an evidence-based medicine specialist, the entire body of evidence tells us conclusively that the blue surgical masks that we've been using and the white masks, the man-made masks, are largely and highly ineffective. They do not stop transmission, and every single place in America that we looked at, or the globe, where you impose a mask mandate, the actual infections increase. So
This was actually one instance where Dr. Fauci was right first, before he decided.
change.
Mr. Kirsch, just real quickly describe who you are, how you got involved in this, and what point you want to make.
Sure. My name is Steve Kirsch. I used to be a high-tech executive. My company was shut down. I started the COVID-19 Early Treatment Fund, was featured on 60 Minutes for discovery of, or for the funding of fluvoxamine, which is proven to be reduced death by a factor of 12, and still the NIH won't recommend it for some reason. And I'm also the founder of the Vaccine Safety Research Foundation.
Okay, you have a mask there you want to talk about?
Yeah, so there are only 2 randomized studies that have been done for masks and COVID. And they looked at cloth masks and surgical masks. And in both studies, there was 0 effect. So the most recent one was the Bangladesh study. And what we did is we got a hold of the original data set that was used for the paper, and we did the graphs. There is no difference at all between wearing a cloth mask and not wearing a cloth mask. The curves were identical, and they misrepresented it in the study as showing that it works. If you actually look at the data and you plot the data, and you can get the data because it's publicly available, you will find that the curves are identical. There is no difference between the cloth masks, and the surgical masks were in between the cloth masks. So if you had a red cloth mask, it worked. If you had a purple cloth mask, it didn't work at all, and the surgical masks were in between the 2. In other words, it's all statistical noise. These masks do not work at all, and the N95 masks are maybe slightly better, but only for a very short amount of time. If you're in a room with someone for any amount of time, even with an N95, it's not going to work. The only mask that is proven to work is the one that they don't tell people about and that nobody wears. This is the only mask that works. So this is called a P100 mask. It is 150 times more effective than an N95 mask. This is the only mask that has a chance of working. It's never been tested for the coronavirus, but it should be 150 times better than almost 0.
I'm a little reluctant to even have you talk about it because I'm afraid the Biden administration just might allocate about $100 billion to send those out to everybody.
Yeah. But here's what it's like. So you put this arm like this, and then you strap it, and then you talk to people just like this. And this will filter it out. But there's a
Again, I'm afraid they're going to require that for air travel. So,
but one important thing is that this mask works only in one direction. It will work to protect you,
but not somebody
But there's no filter on the outside, because if it was filtered on the outside, you wouldn't be able to breathe.
Right. Okay.
So it works, but it only works one way. And if they were really serious about protecting the American public, they would require everyone to wear this, in which case everyone would rebel and we would have no mask mandate.
And of course, one other point on masks, and we don't have a psychiatrist unless somebody wants to speak to this, but I think it's obvious. I don't think we really need the harm done to our children in terms of development, speech. I mean, all these things have been written about widely. I mean, just even their oxygen levels.
Senator Johnson, there's one important study that actually ties everything up. It was the Swedish study by Ludvigsson, and he was canceled because of this study. He looked at the 1.95, I think you mentioned it.
1.8, I thought.
1.9 million Swede kids across the entire pandemic, from 0 to 16 years old, all in primary school, secondary school. And what they found was that there were 0 deaths in Sweden in children. And what was critical about that study was that there was no lockdowns, there were no school closures, and there were no masks. It was not even testing whether you had masks and it worked. There were no masks, and there were 0 deaths. And that was an actual seminal study, and thank you for mentioning it.
Well, again, we've talked about the stratification of severe illness with COVID that's been ignored, but Dr. Urso.
Yeah, I just wanted to enter into the record, clean this up a little bit. Masks have been looked at for 3 decades or so, where there's been randomized controlled trials. So there's roughly, 12 or so randomized controlled trials. There's 0 randomized controlled trials that show masks stop the spread of respiratory disease, and that's including N95. And for everyone, N stands for non-oil resistant, 95 stands for 95% airborne particles, of which all viruses fit through. So I usually tell people that, wearing an N95 also has not been shown in randomized controlled trials to be effective. But more importantly, the capsule on these viruses are an oil capsule, and I tell people it's like peeing in a pool. It goes right through. It doesn't stick to water molecules. It's an oil capsule virus. At the end of the day, the data is what it is. There's 0, repeat, 0 randomized controlled trials at all showing that masks stop the spread of upper respiratory disease.
So let's move on to the second pillar, discuss early treatment a little bit more robustly. And I'm actually going to reward one of the, we're getting all kinds of questions from Rumble, and I wish we could answer them all, but I've got one here from Sand M, it says, but my adult children, both fully vaccinated, got COVID, could not get treatment from doctors in Virginia, and they did not have mild cases. This person asked, what is the definition of mild? What I want to talk about is, my first question, because I've heard this from so many constituents, so many people I've talked to that get that test, start getting seriously ill. And because NIH, because, I call them the COVID gods, literally have no recommendations. I mean, the only people, you've got FLCC here, you've got Dr. McCulloch's protocol, that's pretty much about it. What is a person supposed to do? It's very difficult to find doctors who will treat. If you have a doctor who will treat, it's very difficult to find a pharmacy that will fill some of these drugs. Some of them that haven't been poisoned, you can get, but the big ones, the ivermectin, hydroxychloroquine, it's very. So what is a person to do when they or a loved one gets COVID?
So could I just answer what the NIH recommendation is, and they've made
Sure.
this public?
Well, no, we want to know what somebody's supposed to do,
Okay, well, the NIH tells you to go home, take fluids, take Tylenol, and you stay at home until you get blue, and you can't breathe, and then you go to hospital, and then they isolate you like a prisoner, give you remdesivir and dexamethasone, and then you die. That's the NIH recommendation.
and we'll get to that phase.
So
3
obviously
here,
what we're saying, and Dr. McCulloch has said this, and all we've said, this is a treatable disease. COVID-19 is a treatable disease. But what's critical is timing. Because of this viral load, you treat early. You don't wait for the test. When patients have symptoms of COVID, you treat them like they have COVID. And there are effective treatments to treat them.
so again, so I understand that, but people can't find doctors like you, okay? They just can't. So before they can find a doctor like you, and hopefully there'll be more, I mean, I know some people are doing telemedicine and online, that type of thing. What are they supposed to do? And I see somebody in the...
Ben, go ahead.
Come on up and introduce yourself. By the way, this is a really important question. This is what people
Yes, sir, this is an important question. I'm Ben Marble, MD. I'm the founder of myfreedoctor.com. So we've delivered over 150,000 free doctor visits to America, delivering the early treatment McCulloch protocol. We've only lost 4 patients. We have a 99.9.
So repeat that. So you've treated through telemedicine
Yes, sir.
150,000 COVID patients.
Yes, sir.
With his team. Yeah.
With your team.
Yes, with the team. We have a team of volunteer free doctors that donate their time to help treat these patients that come to us. They go to myfreedoctor.com and they answer our questionnaires. We deliver the early treatment protocols to them as early as we can. and we have a 99.99% survival rate. So I believe myfreedoctor.com, the volunteer free doctor team, we have settled the science on this. Early treatment works, period.
Okay, so let me. So let.
Excellent.
So I will repeat this. So it's free doctor.
Myfreedoctor.com. My.
Okay, okay. Can you tell me tell us the cornucopia drugs you use. What is your basic protocol? Are you using one
We're
of these?
using the McCulloch protocol, which is essentially the controversial drugs, of course, ivermectin, hydroxychloroquine. It also includes monoclonal antibodies, prednisone, budesonide, and several other prescription drugs that are low-cost generic prescription drugs. And of course, we use the over-the-counter, vitamin D, vitamin C, zinc, quercetin.
Well, you mentioned budesonide together with Senator Paul, and I'm sorry, I'm terrible with names, a doctor in Texas. We sent information after a study in England saying it was what percent effective? It was over 80%. And again, we still don't recommend that. Dr. Corey, thank you very much. First of all, thank you for being a doctor. Thank you for providing that service.
Thank you, sir.
Yeah, I just wanted to second the applause to Dr. Marble and his service and his practice. Your question of how to treat this, in my opening statement, I called out the corruption, right? The corruption is because they don't want you to use off-label, repurposed generic medicines. It does not provide profit to the system. And so that early treatment and its efficacy and the availability is being suppressed. What had happened in this country, and I have to call it out, is, again, I use the words absurdity and an obscenity, but these are crimes. You know what's going on in this country right now? Is that the CDC has been captured by the pharmaceutical industry. They sent out a memo in August of 2021. They sent out a similar memo back in the spring of 2020, telling the nation's physicians and pharmacists not to use generic medicines. We are now in a state in this country where Senator Johnson asked the question, how can we get the average U.S. citizen to treat or get treated? We have pharmacists across the land who are refusing to fill these because they've been manipulated and brainwashed into thinking that the FDA hasn't approved the use, as if that matters. Off-label prescriptions and prescribing has been going on for decades. It's encouraged when there are no effective treatments. Yet I have to, when I try to treat my patients, and Dr. Marble can attest to this, we have pharmacists who refuse to fill some of the safest and low-cost medicines known in the history of medicine. Dr. Marek talked about that. These are extremely safe, extremely low cost. They do not provide profit. The CDC has intervened and have manipulated the doctors. I need to make that message clear to all physicians in the land. These are highly effective medicines. They're not being used. The pharmacists are not filling. All the pharmacists in the land, you have to understand that you are obstructing the good and sound conduct of medicine. It has to stop. It has to stop. We have people dying. And, Dr. Marble's practice, the volume of patients that myfreedoctor.com has served is really almost miraculous, right? However, there also are other telehealth practices, and I don't want to take away from Ben, but our nonprofit organization, on our website, we have a button which says Find a Provider. We've tried to collect as many telehealth providers that treat all states in the country, and that is a resource. We've done that as a public service. We are trying to let that message be known, because that message is being suppressed, that this disease is treatable. There are providers that treat, but how to find them is hard. And I'm glad you asked this question, Senator Johnson, because it's absolutely, I keep calling it out. These are crimes against humanity. We have patients who are falling ill with a treatable disease and they can't get treatment.
So let me before I kind of ask my next question, you published in your website or in your Substack, what are these called again? What kind of?
Those are called novel, barely tested, highly profitable.
No, I mean that type of chart.
Okay, that chart is called a forest plot.
So this is a forest plot of all the different types of drugs. I know it's hard to see. All the different drugs that there have been some research on. And what was interesting about this chart is Dr. Corey circled the ones that are recommended by our health agencies. They all range from $700 up to $3,200. All the ones that are not recommended are the ones that are, a couple bucks. Go figure.
Senator, can I have a word on? So that website, by the way, that lists all of that you just referred to is called c19early.com, and you can see a list of all of the treatments that are available to people. And so if people cannot get treated by their doctor, they can look at that list and they can take the things, because a lot of the things on that list, like vitamin D, NAC, even aspirin, these can all be gotten over the counter without a doctor prescription. And so if you can't get treated early with a doctor, you can use one of those. Also, I want to mention the George Fareed and Brian Tyson and acknowledge their work. George was going to be here today. He is unable to attend, but his protocol, he's treated over 7,000 patients, not as many as Ben, but they're a small two-doctor practice. They've treated over 7,000 with 0 deaths.
It's 10,000 now.
Okay,
10,000.
and they tried to reach out to the NIH in March of 2020 when this first started with their protocol, and they were ignored. And they tried reaching out again and again, and they were ignored. And even today, their protocol is still ignored, even though there are 0 deaths from anyone who got their treatment protocol. It's available on the web. They also have a book out now, but that's available to people if you can get a doctor to prescribe it. And also, one final thing is fluvoxamine. And I know a little bit about fluvoxamine because I funded both the phase 2 and the phase 3 trials on that. Now, trying to get a doctor to prescribe fluvoxamine for COVID is very difficult. But if you happen to be depressed when you've gotten COVID and are depressed about it, you can go to your doctor and say, well, could I get some fluvoxamine for my depression? Or maybe you have a hand-washing obsessive compulsive disease, or maybe, or wearing masks, or you're obsessively, touching your nose. You can get a prescription for fluvoxamine for that obsession. And by the way, it might just cure your COVID as well. Just fluvoxamine alone, 50 milligrams twice a day for 14 days.
Okay, so I think so we have Dr. Mangat. You want to say something?
Just coming to your question from Virginia. I practice in Maryland, and it's a familiar problem I'm seeing from Virginia, that the Virginia pharmacists are difficult. And even my patients who live in Maryland and work in Virginia face the same problem. But the key answer is to find a doctor who is going to treat you. And then that doctor has got to be cognizant that a lot of his scripts will not be prescribed. Like I have patients in Virginia, I treat them. I have to figure out where I can get the relevant drugs. And that often means independent pharmacists. So you've got to look there, stay away from the CVSs. Costco ain't bad, and you just got to figure out who has it. And that's a key question, and have your patient work with you to identify and find those places.
So by the way, that's where I've referred people to doctors that actually treat. The first thing I'll say is find a pharmacy that will actually fill the prescription, and it's an independent one. But let me ask those of you who have utilized this cornucopia of cheap, generic, repurposed drugs, have any of your patients had an adverse reaction to ivermectin, hydroxychloroquine, just budesonide, Dr. Cole?
No. I've treated 400 patients. Not a single one's gone to the hospital. Not a single one's died. Half of those were elderly, comorbid, high risk. The only thing that's happened as an adverse reaction is I've lost 1/3 of my business because insurance contracts have pulled away from me for unprofessional conduct for using these dangerous drugs, ivermectin, for which my patients have had no adverse reactions. I've treated 500,000 patients or diagnosed 500,000 patients diagnostically in my career. I have not had one single complaint against me. I have 4 complaints against licenses in 4 different states for saving lives. So the adverse reaction from these drugs is being attacked for being a good doctor. That's the bad adverse reaction, and I know many of my colleagues on this panel as well.
Okay. Dr. McCulloch?
I want to give just a fair, balanced statement. And again, you're going to see this among doctors. I'm a cardiologist, so I manage some of the highest risk people in medicine. I have lost patients, and patients do die of COVID. And I can tell you 201, the patients that I've lost, it's because we've gotten a late start on early treatment. I recently published a paper with Fazio and colleagues from Italy. We have shown the golden window to treat COVID-19 is the first 72 hours. And the patients that I have lost, and they've been very few, but if people listen to this out here, they will recognize that it's a late start at treatment that is, in a sense, the failure of early treatment. If we start early, we have uniform successes. I've reviewed hundreds and hundreds of reports of hospitalized patients and of those who've died of COVID-19. And in those reports, the clear observation is the determinants of hospitalization and death are the lack of early treatment.
Yeah, I want to echo that. You know, as head of the COVID-19 Early Treatment Fund, we see early treatments from all kinds of different doctors. And what makes the difference is not which early treatment protocol you are on. If you get treated early within that 72-hour window, nobody dies. It doesn't even matter what protocol you're on. If you get treated within those 72 hours, I have never heard of a single case of anyone dying.
Okay.
I want to address...
Just real quick for my staff, can we do my censored chart? Is that available? If it is, put it up. Dr. Russo.
I just want to kind of go off what Dr. McCullough said. Really, we're looking at the risk, but the question begs the risk-benefit ratio. That's really what we're getting at. Is there a risk for low, these low ivermectin, hydroxychloroquine? I always tell people, yeah, hydroxychloroquine's got so many side effects, like Dr. Parks talked about. Lowers the cholesterol, lowers the hemoglobin A1C, lowers the glucose, lowers the insulin resistance, lowers D-dimer, C-reactive protein, sed rate, decreases stroke, heart attack, pulmonary embolus, decreases chronic kidney disease. So there are a lot of side effects associated with these drugs. So that's one. I don't want to finish.
He's being very facetious. Those are all benefits.
There are now 96 clinical trials going on at clinicaltrials.gov for use of hydroxychloroquine in cancer, so solid tumors. So if you go to clinicaltrials.gov, that's where you're going to see. So these drugs have a lot of side effects. They're really, for the most part, wonder drugs, and they can cause side effects. And jokingly, I was being facetious earlier, but they can cause GI side effects.
You really need to point out how facetious you were being. I mean,
okay, all right.
No, I'm dead serious about that. I mean,
in case you didn't know, lowering the glucose and lowering the rate of stroke and heart attack is a good thing.
Yeah, those are benefits, not side effects.
The bottom line is that many of the drugs, like azithromycin, have wonderful effects on so many levels, on inflammation, on viruses, on many things that you would. I've been using it for 20 years for scarring. So if you look at what we're prescribing, and you talk about the risk-benefit ratios, what we are prescribing is very, very low-risk drugs over and over, and you can compare those the ones that have been developed by Pfizer and Merck. One's a molnupiravir, which is a nucleoside analog, and I want to go into this because I think it's important. These are not creative thoughts. These are old drugs from the 1950s that have been dressed up and put back out there, and they are literally, they're going to kill viruses because viruses use the same machinery we do, but they'll also kill your mitochondria, they'll also kill your normal cells. They're actually not too bad at killing cancer cells, anything replicating quickly. So we are seeing the use of Paxlovid, which is like a Kaletra 2.0. So we are seeing drugs sort of being dressed up and repurposed. They are repurposing themselves and putting a price tag on them. They are using repurposed drugs with a higher price tag. Everyone needs to know that.
They get to repatent them.
In their own way. So that is one of the issues with what we are seeing. These are not creative things. Remdesivir, that is not creative. Neither is molnupiravir. I cannot say that enough. It is not a creative thing. The drugs we are talking about are wonder drugs. They really are. Ivermectin, hydroxychloroquine, azithromycin, superheptadine, Pepcid, there's a whole list. I've got I won't go through them, but there's a lot of things we can use. They're incredibly safe. And you can save lives. We've had people save lives without hydroxychloroquine and ivermectin. There's a doctor from South Africa named Dr. Shetty, we all know. He saved over 7,000 people without using any of those drugs.
So I guess my chart's been banned by my staff as well. But let me just quick summarize it for you, because it just points out in very stark terms the safety profile of some of these repurposed drugs versus what we're seeing through the VAERS report with the vaccine. Ivermectin over 26 years, on average about 15 deaths per year reported and associated with it. Again, VAERS and FAERS, this is how FAERS does not prove causation. So 15 deaths per year on average. Hydroxychloroquine, 69 deaths per year over 26 years. The flu vaccine, about 77 deaths, I think it is. 77, oh, it is that. Oh, great. It wasn't banned.
You're hitting
yeah, no, I'm an accountant. I remember numbers. But you take a look at remdesivir. It's over 1,600 deaths since it got its emergency use authorization. And now, unfortunately, with the COVID vaccine, 22,000 deaths reported on VAERS. Again, we all recognize VAERS does not prove causation, but 30% of those 22,000 deaths occurred on days 0, 1, or 2. It certainly raises alarms to me. I don't understand why it hasn't raised alarms to the FDA. And so what I want to go back over to, because it's on the same subject, Dr. Wiseman, one of the first things I really recognized in terms of things you had done is your video you put together in terms of the advisory committee meeting on molnupiravir. And very quickly, and again, let's not get too far down the weeds, but that advisory committee barely recommended it. It was a vote 13 to 10. Can you just hit on and again, I personally hope that molnupiravir, Paxlovid work beautifully. I mean, anything, I will embrace anything. I am completely agnostic when it comes to whatever drug will end this pandemic. Vaccine, whatever. I don't care. I want this pandemic over. I want people to live. But just talk a little bit about molnupiravir in terms of that study, and if you've got something on because I know you've also done some work on Paxlovid too, but again, succinctly.
Okay, so thank you. I would encourage everyone to watch that AMBAC meeting. AMBAC is the committee for the FDA that deals with antimicrobial drugs, because that, to me, is the closest to any real discussion of safety and efficacy of any of the agents that we've been talking about. And what's remarkable to me is that it hasn't been repeated. It wasn't repeated with Paxlovid, and it wasn't prequelled with the vaccines. But in that meeting, you had very, very good discussion among top FDA toxicology people who expressed serious concerns about molnupiravir. And amazingly, Paxlovid didn't go through the same procedure afterwards.
But again, the concerns on molnupiravir were?
Excuse me?
The concerns about molnupiravir were?
Okay, so the main concern with molnupiravir is that its stated mechanism of action is to induce mutagenesis. It's to make a storm of mutations so much that it discombobulates
So what could go wrong there?
So what could go?
And their solution, the solution of that problem, which Merck was asked and they had no answer for, the solution was?
Well, they didn't really have a solution.
Well,
the solution was, well, we have to be very careful. We'll keep monitoring it. We'll make sure that variants don't come up. In fact, but what surprisingly, Senator, was that, and I've got the documents.
Well,
here.
as I recall, the solution was we're going to make sure that everybody stays quarantined on molnupiravir.
Yeah, but
and they were going to take the full dose.
Right, but you know what? When you read the approval letter, which I happen to have here. I've got the approval letters for molnupiravir, Paxlovid, and remdesivir.
Yeah, I don't want to take too much time.
I'm not going to, but surprisingly, all the safeguards that the committee members, even the ones who voted in favor of it, right, were saying this, many of them, the safeguards that they had, because the concern is, are we going to spawn dangerous mutations? And that may even be the reason why we've got a funny uncle, who knows, because we've already got molnupiravir working on it. Okay, but the concern is that we may be spawning dangerous mutations. And there's all sorts of precautions, like you mentioned, and hardly any of them are mentioned in the molnupiravir approval letter. Paxlovid didn't have a committee member. Has even more things that they mention in the Paxlovid letter about mutations and resistance.
Plus,
and
it has
that
to be
type of thing.
taken with a drug that interacts with a bunch of common drugs, and it's got a long list. Of,
Okay, that's okay.
Totally separate stuff.
Okay, that's another issue. So, but the main point, I think, I mean, many points, is that here you have absolute hypocrisy from the FDA. Here they're waving through molnupiravir, Paxlovid, with, as you said, with a long list of adverse events, okay, and hydroxychloroquine and ivermectin and fluvoxamine, which are relatively innocuous. You've got the chart over there. Nothing. This is absolute hypocrisy. And so what's important about molnupiravir, it serves as a warning for all of us. That's what should have happened. They should have had those discussions for the vaccines. They should have had the discussions for the Paxlovid, and they should apply hydroxychloroquine through the same channels. And we have data. Pierre and I co-authored a paper. We reanalyzed the key study that closed down hydroxychloroquine for post-exposure prophylaxis. We showed it was completely wrong. There was missing data. We found the missing data, 42% reduction. Not only that, the similar group that had a early treatment version of that study, they won't even supply us with those missing data. We know the data's there. They won't even supply it to us. And so those are the studies that close down hydroxychloroquine. Those are the ones that FDA need to insist on getting those data. The New England Journal of Medicine need to insist on getting those data. Annals of Internal Medicine need to insist on getting those data. So you talk about corruption and coercion and co-option of the peer-reviewed literature and FDA. Here it is right there. We've got the solution. FDA can get out of this tomorrow.
So this is where I wanted to start transitioning into Dr. McCulloch, who we've talked to in the past. Because you were calling for, you know what they're called, these independent safety review panels, or I mean, you've got the exact name for it. Talk about, as Dr. Wiseman just did, talk about what we didn't do in the approval process, in the safety surveillance, the follow-up process. Talk about the steps we didn't take that we should have, and what we ought to be doing moving forward.
And my comments will be regarding the COVID-19 vaccine. So Pfizer, Moderna, Johnson & Johnson. I have served on or chaired over 24 data safety monitoring boards for NIH-sponsored and big pharma-sponsored clinical trials. I know data safety inside out, backwards and forwards. I've also been on critical event committees, and I've been on institutional review boards. Those three bodies are essential. I'll repeat. A critical event committee to adjudicate a safety event. A data safety monitoring board to independently look at what is going on with a clinical program and when an investigational product is being administered, and then a human ethics board to understand and help protect the subjects in that study. We have an Office of Human Resource Protections here in the United States, OHRP. They are charged in protecting human subjects. Our COVID-19 vaccines, the consent form indicates in every state in the United States that the vaccines are investigational or in research because they are under emergency use authorization. What did not happen is we did not have those three essential bodies of independent people installed. We never had those. By the way, they were installed and were utilized in the randomized clinical trials before they came to EUA approval. We also had the wrong bodies leading the vaccine program. Remember, the FDA is supposed to be the safety watchdog. The National Institutes of Health is the government research body, and the CDC is the outbreak investigation body. Right now, the CDC and the FDA are the named sponsors of a vaccine program. If American can learn anything, we should never have the FDA and CDC be a sponsor of a public program in administering a product. It has been a giant and colossal mistake. We should have had a separate body, a government body, be the sponsor of the vaccine program. The vaccine manufacturers can supply the products, and then we needed the separate Data Safety Monitoring Board, Clinical Event Committee, and Human Ethics Committee there in oversight. And if this would have happened based on the emergence of unexplained deaths, I am testifying today that the program would have been shut down in February because of excess mortality.
The NIH Specifically, the NIAID division of the NIH co-owns the patent on the Moderna vaccine, and 6 members of the NIAID get royalties from the profits into their personal pockets, not to mention the entire budget of that program.
Are you sure of that?
I'm sure of that.
Is that
That's publicly available information. Okay. 4 members get royalties.
I know there's also an issue, not to, there's also an issue of the people that on the panel for remdesivir had some kind of tie with Gilead as well.
Rife with conflicts of interest that would never be accepted in other settings. So they are profiting. And look, NIH, just for people out there that don't know where these agencies are situated in the federal government, NIH, which is gotten involved in sponsoring the research, the studies, for approval of the vaccines, FDA, which is the agency that gives approval, and CDC, which is the agency that makes recommendations on which subsequent mandates are based. So the CDC says, well, we don't mandate anything, we don't make federal policy, federal law, which is true, right? But all the mandates then look to the CDC recommendations as their justification. So nobody ultimately takes responsibility for the mandates. There's no place where the buck stops. All of these are divisions of the same Department of Health and Human Services. They all report to the same secretary of the Department of Health and Human Services. And the need for strict separation from those who are profiting from these products, right? Which is what we expect corporations to do. Of course, that's what they're about. But all the more need for careful structures to be put in place such that the regulatory agencies are serving the interests of the American people.
Then there's also a revolving door between the agencies and the pharma.
Exactly.
And I won't name any names, but we've seen it in the
You can
recent
trace
times.
their careers as they rotate through these agencies into pharma and back.
So let me transition. Dr. McCulloch talked about the CDC, NIH, FDA kind of not playing the roles they should have played. What about the health agencies in general dictating how doctors practice medicine and how foreign that really should be to how the structure is set up? And why is that? I mean, I realized, $140 billion worth of grant money flowing through Dr. Fauci over decades. So talk a little bit about what has happened to
One more
medical
comment on that.
establishment.
Yeah. I received a letter from the California State Medical Board maybe 6 months ago. Went out to all physicians from the medical board saying, any physician in California who writes an inappropriate exemption for masks or other COVID-related measures will have his medical license subjected to investigation and disciplinary action. So for a physician, just to help you to understand, this kind of threat hanging over your head is worse than the threat of getting fired. If I get fired from a particular healthcare organization, I can go to another healthcare organization or go start a private practice. If I lose my medical license, I cannot practice medicine, okay? That's how serious this is. The letter never defined what might constitute an appropriate or inappropriate mask mandate. So I have no idea if I write a mandate for a kid with a severe anxiety disorder that's worsened by the wearing of a mask, is that going to subject my medical license to disciplinary action? Physicians in California interpreted the phrase and other COVID-related measures to include vaccines, which had already been rolled out at that point. It has become de facto impossible to get a medical exemption for a COVID vaccine in the state of California. No physician will write them, even when you have someone that has a contraindication listed on the CDC's list of contraindications to COVID vaccines. I have a patient, went to her rheumatologist, specialist in her autoimmune condition. This specialist told this patient, I don't think you should get the COVID vaccines, given your age, your low risk of COVID, and I think there's a good chance that these vaccines, based on the data that we have, could worsen your underlying medical condition. She turned to the same physician immediately afterwards and said, can you write me, therefore, a medical exemption? because I need one for work. There's a vaccine mandate at work. Same physician that just told her not to take the vaccine or recommended against it said, no, I'm sorry, I can't write you a medical exemption because I'm afraid I might lose my license.
Are you telling me that patients who have known life-threatening contraindications
That's
to
right.
receive a COVID-19 vaccine indeed are not being given exemptions?
So the medical boards are behaving very irresponsibly, doing the bidding of governors who want to impose certain mandates, in this case, mask mandates or vaccine mandates. They're not serving the public good. In this case, they're certainly not serving the interests of patients. And they are, again, in my entire 18 years of being a licensed physician, I and my colleagues have never, ever received any kind of communication like this from the medical board. It's outlandish.
And to your point, Dr. Cariotti, they never define.
Exactly.
They threaten you, and it's this looming threat without definition. You're spreading misinformation. Oh, do cite the papers in which I am spreading misinformation. They will not define it. They will attack you. They will threaten you. They will put you in a state of fear and say, you can only do what we say, but don't save a life. And by the way, the vaccines are expired because Omicron is here. And now they still want to mandate them. So they threaten us and threaten us and threaten us, and we're hunted for caring and being compassionate and empathetic and wanting to help humanity.
I want to correct one thing that Dr. Chiardi said, which is there is one physician in California who will write a medical exemption and a mask exemption. There is one physician.
I wouldn't name him.
Yeah.
Yeah. So,
believe me, he doesn't want to be named.
yeah,
But he is being investigated.
okay. So a little ahead of schedule. I see Brianne Dressen has been somewhat the spokesperson for some of the individuals that have been experienced injuries. So Brianne, why don't you two introduce yourself? For some reason you wanted to address this issue.
Yeah, so I'm Brianne Dressen.
Get it close.
I'm Brianne Dressen. I